Welcome, friends. This is Dr. Jaitly, your cardiologist, on your favorite video site, MuniMeterHealth, which is being shown on several social platforms, primarily to enhance medical education, along with the patient education to improve the clinical outcomes, as we know. And that's been my deepest belief. I sincerely thank you for being associated with MuniMeterHealth, your favorite site, in order to achieve clinical outcomes. And remember, please mind that this is purely an educational channel. It's not a substitute to your syllabus, specifically for my medical students, residents, and fellows who are taking the exams, etc. It's always a supplement to your syllabus that's been prescribed by universities and your societies. So without any further ado, let's delve into the subject matter. And of course, if you're having an emergency, please go and see a doctor right away. Call 911 if you're in the United States, etc., etc. Okay? So remember, this is only an educational channel. It's not a treatment advice folio or platform either. Now, my short subject, which I pick up on all these short video vignettes, are what are 10A inhibitors. Now, we know that there are several, it took several years rather, for warfarin-like drugs specifically. And remember, warfarin, of course, has been around for like several decades now, almost like 40, 50 years. People have been using the form of a drug called Coumadin, Coumadin, and that requires a very close INR monitoring. We know that, which is your prothrombin time, and that needs to be monitored because it has a very, very narrow therapeutic index, the warfarin drug. Again, as I said, it's one of the best drugs that has been around for so many years. But the novel anticoagulants that came around in the last 5, 7, 10 years have been not attacking really the prothrombin, but more so utilizing the factors which are responsible for coagulation cascade, if you will. Now, here is a very short cascade that I drew here. I know it's more complex than what it appears here. But just for a quick revision, remember there is a factor called 10, and that factor 10 is converted into a 10A by either an intrinsic pathway, which is formerly known, and today it's known as contact surface activation pathway, and or extrinsic pathway. So there are two pathways. Remember, there's an intrinsic pathway and there's an extrinsic pathway that will activate this factor 10 to go into 10A, which is active. 10A is active. So the extrinsic pathway being the tissue factor activation. So you have a tissue factor activation and you have a contact surface activation going on here. Intrinsic and extrinsic respectively. So as a matter of fact, one tends to believe that once the factor 10 is activated to 10A, the cascade of coagulation begins, like shown here. Prothrombin will then be converted to thrombin in the presence of 10A, and in the presence of thrombin, fibrinogen will be converted into fibrin. And the fibrin, as you know, there's the clotting mesh, or the real substrate, which combines with platelets and platelet factors to form the clot. The eventual clot will be formed here. So this is in a short way of knowing that 10 activates to 10A, prothrombin then activates to thrombin in the presence of 10A, and fibrinogen then activates to become fibrin, which is the readily clotting substrate in the presence of platelets, again because of thrombin that's present here. So these are three major steps, if you will, in the entire coagulation cascade. And of course there are minor ones which we have not discussed here, but just so that you can supplement in your syllabus, or look into your syllabus rather. So, but then there are drugs which will act on these levels, which have been now the novel anticoagulation mechanisms which have come in place of warfarin. Not necessarily substituting warfarin. Warfarin has its own indications. We are just going by where we have newer, novel mechanisms where these anticoagulants can work. The prototypes are two examples. One is apexiban and the other is rivaroxiban. I wrote it down here for convenience, and in brackets, obviously, Eliquis is the brand name and Xarelto is the brand name here for rivaroxiban. Now, these two drugs, remember, they both require renal clearance. So they will require a renal clearance for any dosage that has to be given. So in other words, creatinine clearance less than 50, creatinine clearance more than 90, etc., etc. They'll require dose adjustments. Now, these two drugs will also be measured by, again, their side effects obviously are hemorrhage, but you can reverse this. If there is a hemorrhage that occurs, you can reverse this by something called 4-complex PCC. Now, what is PCC? Basically, it's prothrombin complex concentrates. So if you use 4 of these, they are called 4 complexes, prothrombin complex concentrates, or PCC. They can reverse the hemorrhage that can occur from as a side effect from these from either of these two drugs. Now remember, these two drugs, where do they act? Now these are, because they are 10A inhibitors, they will work here. So as simple as that. So I'm going to just draw an arrow here and bring it down here, for instance. So this is where these two drugs will act. They'll act on the 10A, which is the activated factor 10, so that once this gets inhibited, prothrombin will not convert to thrombin, and therefore fibrinogen will not convert into fibrin, and therefore you can maintain an anticoagulation. Remember, these are anticoagulants. Remember, these are anticoagulants drugs, okay? So because they are anticoagulants, they will prevent the clot from happening. And therefore, a 10A inhibitor here will work to prevent the prothrombin converting to thrombin, and therefore fibrinogen converting to fibrin, because ultimately the clot will not form in the presence of anti-10A, because they are anti-10A drugs. They are like 10A inhibitors, as I say. Okay? Now, similarly, something needs to be inhibited here. So if you could inhibit, say, by DTI, we call them direct thrombin inhibitors. So the full form for DTIs are direct thrombin inhibitors. Now, where will they work? Obviously, without any further explanation, they will work at this level. I drew the arrow here. In other words, now they will have a negative action. So they are anti-thrombin drugs, or direct thrombin inhibitors, or anti-thrombin-like drugs. And the classic example is dabigatran. Virilidine has been around for a while, and then so has argatroban. But remember, these two drugs have been parenteral. They can be given orally. So we needed an oral drug in order to really form some indications, and we'll just go over the indications briefly. And DTIs are the other groups of drugs where dabigatran, for instance, it's also sold as Pradaxa, and Pradaxa has been also an oral drug now, and that is now being used as an oral anticoagulant in place of Coumadin, because where Coumadin may not be used, or where may not be preferably be used, because remember, Coumadin requires blood tests very, very closely, like pretty much on a month to 2 months basis, because you need to measure the prothrombin time, and you need to measure the INR, because that's how it's measured, as it has a narrow therapeutic index, as I said earlier. So very, very important 10A inhibitors. There are 2 examples, apexiban and rivaroxiban. And the DTIs are dabigatran, virilidine, and argatroban. Again, these are tongue twisters, but just remember the prototypes only for now, but of which dabigatran is the oral form. And there's, now, what are the indications? Now, that brings us to a very, very important area. What are the indications where you'd want to use these drugs? Well, first of all, non-valvular atrial fibrillation. Remember that. So that's where they have a good role. They have also a great role in venous thrombo-embolic phenomenon, and therefore in prevention of, say, PE, pulmonary embolism, because the deep vein thrombosis and non-valvular atrial fibrillations and prevention of pulmonary embolism, these drugs are wonderful because they can be given orally, they can be all given PO. They do not require any monitoring, so no monitoring is required, and they are all adjusted. Remember that. Even these drugs, by the way, they are also renal, so they're all renal adjusted. I'll just write it down here. Renal adjustment required. And of course, should there be any hemorrhage, that is, which is one of the serious side effects of any anticoagulant, because anticoagulation tends to thin the blood. So, quote unquote, thinning of the blood requires, obviously a close monitoring. But the fact is that, say, if there is an unforeseen hemorrhage that occurs as a side effect. And so that will require renal adjustment, obviously, but at the same time, you can use 4-PCC. As I said, those 4 complexes of PCC, they could be used to reverse all this hemorrhage. So these are the major indications. Renal clearance is required. Just points I'm saying. They are replacement drugs to warfarin, where warfarin may not be preferable. The only problem is these drugs are really used ideally where you have a good renal clearance, where you have less than 75 years of age, etc., etc., and patients only prefer not to be monitored for their blood tests that often. Like specifically, if somebody is it's very hard for them to monitor, etc. They're active people; they are constantly moving around, and of course, they are younger groups. So there, you can certainly advise, and provided they have met all these indications, that's very, very important for us. Okay, so in a nutshell, I've explained to you what are 10A inhibitors and what are DTIs, and their prototypes, their renal clearance adjustments required for their dosages, and of course how they work in terms of a coagulation cascade. You fully understand where the 10A anti-10A drugs will work, like the Eliquis and Xarelto, and where will Pradaxa work will be at the anti-thrombin level right here, because it's a DTI like drug. So these are the ways where on the cascade these important drugs can work, and again, you do not require any blood monitoring here at all, and they all can be reversed by giving 4 complexes pro-PCC. Okay, wonderful. Thank you so much for being with us on MuniMeterHealth. This is Dr. Jaitly, and until we meet into our next video,